Hi, I'm Rosina Badr Munir, and today I'm going to talk about the COVID-19 lung ultrasound. So, in the market, there are a lot of machines, ultrasound machines are available. The most commonly used machines are the one which are the cart-based big units, which are in the most of the hospitals and in the clinics. Then we have the portable, the laptop type ultrasound machines. And now, with the availability of the handheld devices, most of the physicians prefer to use the handheld machines for the bedside exams. Now we are going to talk about the important knobs which you need to know when you are scanning for the bedside. So here is the control panel where you see a lot of knobs are present on this control panel. So all the for the bedside exam or for the point of care ultrasound, you need to know the some of the knobs. The first is the knob by which you know that how to freeze your image. The second one is how to record the video clip and then to replay the video clips. The another knob is the measurement. When you freeze your image, and then you should know the use of this measurement knob. You can take the measurement on the frozen image. And then is the gain. Some of the machines have the B written on the top of it. B means the brightness, so the gain and the brightness is the same knob, the function is the same. Then is the knob which is marked as the depth. So let's go. So some of the tips for the scanning is that I already mentioned previously that the depth is very important because you need to keep a proper depth for the proper evaluation and the interpretation of your image. So if you look at over here in this image of the ultrasound, this is the lung scan. So if you look at over here, the depth over here is 10 centimeters, and all the anatomy you see over here, the anatomy is lying all the way up till here, so you can see the anatomy up till here. So rest of the space which is over here is just the wasted. So first thing you remember that you should keep your image at a proper depth so that the most of the screen of the monitor is occupied by the underlying structures anatomy. So this much where you can see the anatomy is just the wastage of the screen or the wastage of the space. And if you look at over here, we have adjusted the proper depth, and now we can see the anatomy more nicer and with a good resolution. So appropriate depth is very important, and try that when you are scanning, don't waste the space of the screen on the screen because this way you will not be able to see the anatomy correctly. So appropriate depth is very important for the correct appearance of the underlying anatomy of the structure which you are scanning. Then is the use of the gain. So just giving you an idea that what does the gain mean. So if you look at over here, the gain over here in this image is very low because you know the image is very dark, so the gain is very low. If you look at over here, the image is very bright and you're not even able to recognize the different structures, so the gain is very high. But in this image where you selected the appropriate gain and you can see the anatomy, you can identify different structures from each other. So this is on the top is like the skin, and then you have the this is the muscle, and then this is the rib. So select the gain at which you can see the different structures and you can identify different structures. So appropriate depth and appropriate gain is very important when you are scanning for the bedside exam. Then comes the selection of the probe. So if you look at over here, this is the ultrasound probe, and the top part where you will see the rubber padding or rubber insulation, this part is called the footprint. And this probe has a curved footprint, so this is called the curve probe or the curvilinear. And over here is the frequency. So the C622 means the highest frequency is 6, and it can be this can be brought down all the way to 2 frequency. So this is the most commonly used probe, which is used for the abdominal exams, and it also used for the lung ultrasound. And then this one you see over here, this probe has a footprint which is rectangular, and it is called the sector probe or the phased array probe. And this one has a frequency written over here. So if you note over here, these both probes have a low frequency, because the low frequency means that when they have an increased depth, and the penetration is more deeper, and you can scan the deeper structures much better with the low frequency probes. The use of the sector probe is that sometimes you also helps this kind of probes helps you to look through the intercostal spaces. Obviously, the curve probe is also, you also scan through the intercostal spaces, but then you have to move your hand so that you can find a good window to look for the to look through the intercostal spaces. Now, if you come over here, this is a probe where if you look at the footprint, it is flat and thin, and this is type of probes are called the linear probes. And if you look at over here, the frequency is from 12 to 4. So these are very high frequency probes, and these are usually the higher the frequency, the lesser the depth. So these probes are usually used for the soft tissue evaluation, for the structures which are more superficial. So always remember that if the frequency is higher, the depth is lesser, and if the frequency is low, they penetrate more. They can help you to look for the deeper structures. So this is the difference about the use of different probes, and keep in mind the frequency of the probes. Now, another important point for the scanning is the indicator. Always look for the marker or the indicator on your probe, and this is very important because of the proper orientation of the image. So if you look at over here, the marker is here, and on the ultrasound image, you also note there's a marker on the image, and also remember they should always be on the right side. Now, when you are scanning a patient, because this gives you a proper orientation of the structure which you are scanning. So when you are scanning the patient, so this is the right side of the patient. So now this side where the marker is here, so this is also the right side. So when you scan, and you keep your probe in a transverse direction. Now remember, when we are scanning the ultrasound, we use two kinds of planes. One is the transverse plane, and one is the sagittal plane. So in a transverse plane, your pointer should always be towards the patient right. So look at over here, we put the probe over here. Now the pointer is facing towards the patient right, and you are standing right over here. And then when you look at the image of the on the monitor, the pointer, the marker on the image is also on the right side. So now you see that whatever is on the right side is this side of the patient is also on the right side. So that's how you will get a proper orientation of the image. And also remember that when you are scanning in the longitudinal plane, the pointer should always be towards the patient face, towards the patient head. So this will help you in the upper and the lower orientation of the image. So everything which is in the longitudinal plane, so everything which is on the top is the superior part, and everything which is towards the bottom of the image is the lower part. Now we talk about the correct probe holding. It is very important that you should hold your probe properly, because the proper grip is very important for scanning the structure, for scanning the patient. And also put a large amount of gel on the patient's surface, on the patient body, so that you should have a proper contact with the skin. So this footprint should have a proper contact with the patient's skin with a copious amount of gel. Now, how to scan the lung? So I always use the 12 examination zone method, which is very easy to use. So just draw an imaginary line in the anterior axillary area. So an imaginary line at the anterior axillary line along the anterior axillary line, and then a imaginary line along the posterior axillary line. So by drawing these two lines, you will divide the chest into anterior part. This is the lateral part. This is the axilla. The patient arm is up, and then this is the axilla. So this part is the lateral part, and this is the back of the patient, and so this is the posterior part. So we divide the lung into three areas: anterior, lateral, and posterior. So then again, draw an imaginary line, a horizontal line, which will divide the lung into upper and the lower lobes. So by drawing these three imaginary lines, you will divide the lung on each side into 6 zones. So altogether, the entire chest you will scan for the 12 zones. So this is a systematic evaluation of the entire lung. Now over here, this picture shows you how to scan. So put your probe starting from the lateral side of the sternum. So this is the sternum area, and then start it from the lateral side of the sternum, and then scan in a horizontal direction, but your probe is lying in a longitudinal plane. So just look at over here. The probe is longitudinal. The marker is towards the patient head. Now you scan from lateral side of the sternum all the way towards the patient anterior axillary line. Then bring the probe down and then scan it all the way towards the medially towards the sternum, and similarly bring it down and then scan it again in display. So thus by the movement, like from here to this axilla, then bring it down, then towards the sternum. So you will scan the entire lung, both the upper and the lower lobes of the lung of the anterior part. Then for the lateral part, ask the patient to put the hand up. So then scan again from lateral to medial side, from side to side, and then go all the way up, all the way to the axilla. And similarly scan from the posterior side, from lateral to medial, and then towards the up, reaching all the way to the scapula. So the tip for examining this the area over here, which is the part where the upper zone of the lung, upper lung lobe is lying. So I ask my patients to just fold their hands towards their chest, so that the scapula is away from the appearance. So scapula moves away, and then you can see the upper lobe of the lung clearly. So this is one of the maneuver that you can apply by moving the patient hands and asking the patient to roll their hand or put their hand towards their chest, center of their chest. Now the most common site of the disease in case of COVID-19 is the posterior lung zones, or the inferior area. Okay, now we will talk a little bit about the normal lung anatomy. So it is very important that you should know the Sonon anatomy. So I use the probes, which are the Sonon 300C, which is the curved probe, and the Sonon 300L, which is the linear probe, for the examination of the lung. And these are the probes from the Hilsirion, which is a Korean company, and these are very nice handheld devices. So let's see over here. So this over here, I'm scanning with the linear probe. So if you look at over here, I kept the probe close contact with the patient chest. It is intact with the patient's skin, and the marker is lying towards the patient head. I put enough gel over here. So when you put the probe on the patient chest, all you have to keep in your mind that you should see the landmark somewhat like this. So look at over here. When you put the probe here in a longitudinal plane, you will see a structure where you see an echogenic line over here, and then echogenic line over here. So these two on the side echogenic lines, these are the ribs, and behind the ribs you will see black shadow. So this is the rib, this is the rib, and in between the rib you will again see a thin white line, and this is the pleura, which is the interface between the visceral and the parietal pleura. So this is the, and you will see the movement of this pleura also. So always remember, and whenever you put the probe on the patient chest, on the patient chest, you need to look for this landmark, the rib, and the pleura. In some of the textbooks, they call this as a bed sign also. So on the top is your skin, then you have a subcutaneous tissue. This is your intercostal muscle, this is your rib, and this is the pleural line. Now, it is recommended that the good image is seen only when your probe is perpendicular to the chest, and then the sound waves are perpendicular to the pleural line. So sometimes what happens that your probe is perpendicular to the chest wall, but you are not able to see this nice pleural line and in between the two ribs, between the two ribs. The reason is because your sound waves, your probe is perpendicular to your chest, but your sound waves are not falling perpendicular to the pleura. So for that, I always say that just rock or move your probe a little bit side to side, a little bit up and down, so that at least you should see this pleural line. So whenever your sound waves fall perpendicular to this pleural line, so you will see this nice appearance of the image. So okay. So now in the normal lung, we are always looking for some artifacts because lung is filled with the air, and the sound wave does not pass through the air. So the evaluation of the lung is based on the presence of the certain artifacts. So if you look at over here, this is the image which is scanned with the linear probe, and this is the image which is scanned with the curved probe. So let's talk first about the linear probe. So if you look at over here, when you put the probe on the patient chest, we see the landmark of the rib and the shadow, This is the soft tissue and the muscle. And then in between is this thin line, which is white line, which is the pleural line. Now, if you look at over here, equidistant from this white pleural line, you see these lines, right? This line, not this one. So this line, and again over this one line, this horizontal line. So these horizontal lines which are equidistant from the pleural line, these are the A lines. And A lines are the reverberation artifact, which is because when the sound beams strikes the pleural line, it is reflected back, and then it forms the reverberation, which is artifact. And these horizontal lines are called the A lines, and the presence of A lines means that you have a normal aerated lung. Now if you look at over here, you see other lines, also horizontal lines over here, but these are not the A lines. These are not called A lines. First reason is that if you look at over here, the distance of this pleural line towards the skin and the distance from here to here is equal to this one. So the equidistant horizontal lines are the one which are called the A lines, and they are all the way like they are more bold, they are more like bright, and they are also complete. So these are the A lines. So if you look at over here, now this is the image which is taken with the curve probe. So now see the difference between the linear probe and with the curve probe. You can see that the appearance with the high frequency linear probe is a little bit more high resolution. You can see the superficial anatomy much better. You can see the pleural line much better with the linear probe, but when you scan with the curve probe, this is the curve probe, you can see a wider appearance of the image. So you can see a big picture of the lung. So you can see this rib, and this is the black shadow, rib, black shadow, rib, black shadow, and in between you can see this pleural line. And then equidistant from the pleural line, you see these A lines, which are the horizontal lines. So this is the A lines. So this is the curve probe appearance of the curve probe scanning, and this is the linear probe scanning. So we talk about the A lines, so I'm sure that now you remember, you can identify that what are the horizontal lines which are called the A lines. Now if you look at over here, I mentioned this long line, the vertical line starting from the pleural line, all going all the way towards the bottom of the screen, and this is very thin, and it is regularly thin, like it is not fainting, it is not spreading. So this kind of line is called the B lines. Now these B lines is again an artifact which is called the comital artifact. So but it is called the B lines. Why? Because this line starts from the pleural line and it goes all the way to the end of the screen. So this is called the B lines, which are the comital artifacts. So here is the B lines. So let's over here in this image, you see these are the A lines. So we will not call this as the A line. Sorry for this wrong labeling. So this is the A line. You see, this is bright, and this is the equidistance from the skin and pleural line. So these equidistant lines are called the A lines. So this is a video clip where you can see the rib shadow, the pleural line, and these horizontal are the A lines. So these are all just the artifacts. The other horizontal lines are just the artifacts, but this one, which is completely going from one end to the other end of the shadow, these are the A lines. So I'm sure now you can identify the A lines. So here are some of the characteristics of the B lines present in normal lung. So in one lung, in one zone, you can see, if you see 1 to 3 isolated vertical thin B lines, so this is considered as normal. So if you can see, these are very thin and they are regular, they are not fainting, or they are not fading, or they are not spreading. So these are the common, these are the normal finding in a lung. So this is a normal. See, you see over here the scanning with the curve probe. So here is the rib shadow, and this is the pleural line over here, and then you see all these horizontal. Let's repeat the video clip. So this is the pleural line, this is the A line, and then if you see, this is the appearance of the B line. So the presence of 1 to 2 or 3 B lines in one zone, these are considered as the normal finding. So again over here, now I showed you with the curve probe. So you look at over here, the thin pleural line, and this is one B line over here also. This is the A line, this is the A line, the horizontal line, and this is a little bit of the closer appearance of the normal sliding sign. So I just want to show you over here, if you see this rubbing of the pleural and parietal parietal and visceral pleura over here, this is called the sliding sign, and this is the rib shadow. And the sliding sign is very important to rule out the pneumothorax. So the sliding sign means that there is no pneumothorax in this patient. And you can see also a very small little thin some areas. Let's go to another video that shows much better the comital artifacts. Now look at over here. So this is the sliding sign, and you see these small little thin vertical lines also over here, which are not going all the way to the bottom of the screen. So these are called the comital artifacts, and comital artifacts is also considered as the normal artifacts finding in the normal aerated lung. B lines which are extending are those which are extending all the way from the pleura all the way to the end of the screen. Those are called the B lines, but the comital artifacts are just a small little vertical lines which you see close to the near the pleura, arising from the pleura. And you also note the sliding sign over here. Okay. Now we look at the when we are looking at the lung at the lower part of the lungs. So you see, for looking the lower part, you just put your probe on the patient lateral side, where you can see the liver and where you can see the right kidney. This is on the right side. So when you see the anatomy like this on the while putting the probe on the lateral side of the patient, so right lateral side, so you will see a bright structure over here, which is on the upper part, which is on over here on the close to the kidney. So this is the diaphragm, and above the diaphragm is the lung area. So you can see, you will look for the pleural effusion or free fluid over here. So this is the one, this is the window for scanning for the pleural effusion and for scanning the lower lobes of the lungs. Similarly, on the left side, you also put your probe on the lateral side, and you're looking through the intercostal spaces. A little bit, it is a little bit hard to look on the left side. On the right side, it is comparatively easier, but on the left side, you have to move your probe a little bit up and down, and you move your probe a little bit, change the probe positioning, not the positioning, but change the probe positioning in contact with the patient body. In a longitudinal plane, it is better to start it from the longitudinal plane. So look at over here. The indicator is again towards the patient head, and we keep the probe over here, and we want to see the spleen and the left lung, the left kidney. So when you look at the left kidney and the spleen, so above that you will see the bright echogenic, the diaphragm, and above the diaphragm you will see the lung. Which you will not be able to see the lung, but it will look more like the appearance of the spleen or the liver. You will not be able to see the lung because it is aerated. In a normal condition, you will not be able to see it. So this is just to give you the idea that how to scan the lower lobes of the lung from the lateral view, keeping the window of the kidneys on the both sides. Now, I always say that when you are scanning for the lung, also have a look of the do a cardiac focus exam, just an eyeball examination of the heart, because lung and heart are somewhat a kind of work together. So for the quick look of the heart, you just put a probe because you're already scanning on the chest. So when you are scanning from the anterior side, just change the position of your probe, so that now instead of your probe indicator in a longitudinal plane, it is somewhat now angling towards the right shoulder of the patient. So if you see in this position, in between the 2 to 5th intercostal space, so now the probe is more pointing towards the patient shoulder, and you can see somewhat like this appearance of the heart, which is called the parasternal longitudinal view of the heart. So just by having a quick look of the heart gives you an idea to rule out any existing pathology of the heart. So now we just summarize the normal lung findings that we look for the bad sign. I already explained you that the landmarks are, which is called the bad sign. The landmarks are the hyperechoic rib, black shadow in between the two ribs, the pleural line. The second one is the lung sliding, which you see over here. Pleural line, when the lungs they are sliding, so this is called the sliding sign. Then is the A line, so this is the A lines, and then the B lines, which are the vertical thin long lines going all the way to the bottom of the screen without fading or without spreading. Now, seashore sign is something which is done more on the M mode, and detail of these signs will be discussed in our detailed course, which will be on the Apna Academy shortly, because we are talking more about the scanning for the COVID-19. So now over here I showed you how to scan. So put the probe over here, and now I'm showing you the ribs and the black shadow behind the ribs. Again, I'm scanning with the Sonon 300C, which is the curve probe, and giving me the this is my tablet, and so I'm scanning on the tablet. And so you look at over here that I can see the A lines over here. So I start from the center of the chest, and then I move all the way towards the patient anterior axillary line. So this is how you scan, and you keep on looking over here on the image the structures, and keep on noting the anatomy. So then I move down. So look at the movement of the probe. The probe is vertical, lying vertically in perpendicular to the chest, and then I move all the way towards the patient center of the chest. And then I move down, and then at the lower area, if you see over here on the screen, I can see the liver and I can see the IVC. So by looking over here, the IVC gives you at least a hint about the hemodynamic, the volumic condition of the patient. And you see over here the liver and the bright. This is the diaphragm, and you can see the lower lung zone in this position. So then I scan from the posterior side. So starting from the lower lobes, then I moved up and look at over here. This is the normal B line. This was a normal B line, the normal pleura, normal B line. Thus for scanning the lateral side, you see this normal thin line, which is the B line, and you see these horizontal equidistant. I always say horizontal equidistant lines are the A lines. You see these other horizontal lines, but these are not the A lines. Okay, one more tip over here is that sometimes it is very hard to see the posterior upper lobe from the back because of the scapula, and even by using the tip, like asking the patient to move the head towards the chest, that even does not work. So in that case, the tip is that look for the posterior upper lobes through the axilla. So if you put your probe in the axilla of the patient and just make your position so that your probe, the sound waves are perpendicular to the pleural line, so then you can even see the upper part of the posterior upper lungs lobe from this window also. So this is in case if you cannot see it from the posterior side because of the presence of the scapula, it is hard for you. So that's how we scan the entire lung, and similarly by scanning all the 6 zones from this side, we scan the 6 zones on the other side, and total comes to 12 zones. Now we will talk about some of the common patterns of the lung ultrasound in COVID-19. I just mentioned only the 5 characteristic findings from collection of data and information from different sources. So in a COVID-19 patients, we have seen that there is a changes in the pleura. So if you look at over here, this is the normal pleural line, and the thickness of the normal pleural line is less than 2 millimeter. But in case of the COVID-19 patients, there is a finding of irregularity in the pleural line, and there is also thickening of the pleural line, because it is a condition where the inflammation and infection has taken place. So you will see the changes in the pleural line, which is the thickening and the irregularity. So this is the one characteristic finding or the pattern which is seen in the COVID-19 patient. Now another one is the B lines, the presence of B lines. Now, the characteristics of the B lines and the number of the B lines is something which you have to keep in your mind. So now if you look at over here, this is the normal aerated lung where you see this B line arising from the pleura. So this is thin and going all the way down. But look at over here. First thing is that you see the irregularity of the pleural line, and then you see the B line which is arising from the pleura. But if you look at over here, it is coming down all the way to the screen, but it is fading and it is more like a torchlight. So this is the early changes in the patient's lung. So you can see over here, and this is the condition which is indicating the late stage or the advanced fibrocystic condition of the lung, because you see the multiple B lines now are combining. So this is the confluent or the coalescent B lines. So we see entire white areas. Now it is even harder to see the A lines, and so this is the advanced alveolar interstitial syndrome, which is seen in the COVID-19 patients also. Now this is the irregular pleura and video. If you look at over here, this is the video clip. So look at over here, the pleura is so irregular and it is giving such a bright white coalescent B lines. And look at over here, this is the normal. So I'm sure that by looking at these two video clips, you can identify that this is the normal B line. So normal B line, thin, and then the sliding sign is still present, and you can see the horizontal A lines also here. But in COVID-19 patients, look at the pleura, you can identify over here. Look at here, it is irregular, and you can see a diffuse coalescent B lines. This is another video clip which shows you the diffuse, homogeneously diffuse confluent B lines, and so the this pattern is correlated with the degree of the lung injury. So look at over here how high diffuse and how bright these areas are. You cannot see any of the A lines in the patient. Now if you look at over here, when we see the B lines over here, and if we see the for example, if you are not able to identify the pleural line over here, so the thing comes that maybe the patient has a pulmonary edema. So I just showed you in a single slide that in that case, when you are scanning the lower part of the lung zone, you can look at the IVC. So if you look at over here, the IVC is not collapsing properly and it is dilated. And when you look at the heart, so you see that the patient has a sign of CCF, though it is dilated, ejection friction is very much reduced, and just by the eyeball evaluation you can see that this diffuse pattern of the B lines is more consistent with the pulmonary edema, because usually, you know, like in pulmonary edema, the pleural line is thin because the lungs become soggy and they are filled with the fluid, and the pleural line is not affected. So then the pleura is usually thin. But in case over here, sometimes it is hard to see. So it is very important that you just have a quick look of the heart also, just to rule out the pulmonary edema. Now in COVID-19 patients, we also see some another finding, which is called the subpleural consolidations. So this is the normal pleural line with the B line over here. Now, if the COVID-19 patients, you will see the when you are looking at the closer look of the pleural line, you will see an irregularity or the dip in the pleural line. So this is called the subpleural consolidation, and in some of the textbooks they also call this type of irregularity as C lines, but we just say as the subpleural consolidation, and you will see the bright B lines below this consolidation, diffuse B line. So this is all the sign of inflammation. And now this subpleural consolidation, we have to keep in mind that we will follow it up to see for the further progress of the disease or the improvement of the disease. So if you see this subpleural consolidation, it is more consistent with the pneumonia. Now if you look at over here, this is the subpleural consolidation, which is seen in early, but later on, with the progression of the disease, it is now changing to the lobar pneumonia, and you will see a big area in the lung, which is more like a tissue-like appearance. So normally you know that we cannot see the lung because they are aerated, but when you see something like a tissue-like structure which has multiple echogenic structures inside it, so look at all these areas of all these foci, echogenic foci. So these are the air bronchograms. Now I'm not going into the detail of the type of air bronchograms because they are static and they're dynamic, because this we will talk about these things in the detailed course in the COVID Academy, in the Apna Academy, Apna Merit Academy course. But just for you to remember related to the COVID-19, if you see something, the lung-like structure, the organ-like structure or tissue-like structure in the lung area, so this means this is the lung consolidation and this is the progressive disease, or it is lobar pneumonia. So look at over here, you see the subpleural consolidations, and you also see these all echogenic structures in the consolidations, which gives you the presence of the air bronchograms in these small subpleural consolidation. And look at over here, the pleura is so thickened and irregular also over here. You see all these diffuse B lines in this image also. Now the four characteristic of the lung ultrasound finding in the patient suffering from the COVID-19 is that there is a skip lesions. What does it mean? That some of the areas you will see the normal lung and then you will see the pathology. So instead of getting the entire disease lining, you will see the segmental areas where you will find the pathology. Again, this is the slide which is showing the pleural effusion. Pleural effusion is not very common. It is a rare occurrence until there is a super infection with the bacterial super infection also. So in that case, you also see the pleural effusion. So you can, I'm sure that most of the physicians are very familiar with the finding of the pleural effusion. So look at over here, this is the normal lung, and this is the normal lung appearance. So look at over here, this is the liver, and this is the diaphragm, and above the diaphragm you see structure which is similar to the liver. So this diaphragm acts like a mirror. Now this is the normal lung appearance, and this is the liver, diaphragm, and the reflection of the liver in the lung area. So this finding is called the mirror artifact, which means that the liver is mirroring over here and you don't see any abnormality. So the presence of the mirror sign means that there is no lung pathology over here. There is no pleural effusion here. Another thing which is called as the spine sign, that if you see the spine sign all the way only up to the level of the liver, so over at this point where the liver right lobe is ending, so you see the spine. Beyond the liver, you will not be able to see the spine. So the presence of liver mirror sign and the absence of spine sign is the normal finding. But what happens when there is a pleural effusion, you see this black area over here, and you can see this consolidated lung over here, and this is more this is indicative of the presence of the pleural effusion, and you can see that the spine sign over here. So the presence of spine sign beyond the end of the liver is the positive spine sign, and you don't see the liver mirroring of the liver over here. So the absence of the mirror sign and the extension presence of the spine sign is the indication of the pleural effusion. Now this is all which is written in some of the textbooks and in some of the videos which maybe you see in the on the YouTube or other sites. I really don't go for that detail, looking for the spine sign or looking for the mirror sign is okay, but not for the spine sign, because when there is a pleural effusion you see the black anechoic fluid in the thorax, in the area of the lung. So which is very much because the presence of the fluid or the pleural effusion is very much easily to see. So instead of going into that detail of looking for the positive spine sign or things like that, I think you can easily identify the pleural effusion, which is very easy and everybody can very easily identify it. Now comes over here that how to have a rough evaluation of that volume of the pleural effusion. The simple thing is that just measure the distance in centimeters from the diaphragm to the lung area, all that area where you see the black and fluid area. So multiply that measurement with 200, and then you will get a rough estimate of the volume in the volume of the pleural effusion in the thorax. Now the last thing is that what is the sign of the recovery phase. So in case of the recovery, you will see the reappearance of the A lines. So reappearance of the A lines means that the lung is now becoming aerated again, and so it is it shows the recovery phase. So if you look at over here, you will again see the reappearance of the A lines, and there is also no changes in the pleural line also. So in summary, we say that for the scanning, always look for your landmarks, which I showed you, the ribs, the shadows, and the rib shadow, and the in between the echogenic pleural line. Then is the proper setting of the patient of your machine. It is better that if you have using the lung presets, if you're not using the lung presets, even in the abdominal presets, you are able to see the all the lung findings. Proper gain and depth is also very important. Angling your probe so that your sound waves, the probe is perpendicular to the chest, and then your sound waves are perpendicular to the pleural line. Obtain good images because this helps you for the interpretation, and if you record the cine loop, this will help you also for the review, for the second opinion, and also store your images because it helps you for the comparison with the patient, whether his patient is condition is improving or it is getting worse. Findings on the COVID-19, look for the pleural irregularities, look for the conferred B lines, look at for the characteristic appearance of the B lines, the number of the B lines. Then in the COVID-19 patients, the distribution is patchy, which means the escape lesions. Look for the subpleural consolidation and look for the distribution. Usually the disease starts at the posterior basal region. Now this is one chart which shows you, which gives you a little bit idea. Clinical correlation, again, it is very important. And if the disease is unilateral, and if it is unilateral and it is diffuse, so the thought goes more towards the large lobar infection or the asymmetric pulmonary edema. But again, over here in pulmonary edema, you have to look for the, you can do the focused cardiac ultrasound and look for the nice thin appearance of the pleural line. Again, the unilateral, if the distribution is patchy, so maybe there is a focal infection. Now on the bilateral, if you find the findings on the bilateral, if this is diffuse, then the pulmonary edema or AR. Yes, so if the condition is bilateral and diffuse, so it gives you suspicious of the pulmonary edema or ARDS. If it is patchy, so it gives you the idea about that maybe it is a multifocal infection, or it is a chronic interstitial lung disease, or viral due to viral infection, some such as in COVID-19. Here is a video clip which is shared by the physician from South Korea. So this is the patient lung, and you can look at over here the bright and the B lines. Look at the pattern and the characteristic of the B line over here. This is the normal B line, and you can see over here that how the B line appear. So you can see the normal lung area, and then you can see in one lung zone area you can see all this diffuse, not very diffuse, but you see the characteristic of this B line, how it looks. It is fading all the way and it is so bright. This is also again the patchy appearance, so normal lung area. And now look at over here, this is all the B lines. Look at the appearance of the B lines, so the patchy distribution and the appearance of the B line. And then look at the thickening of this of the pleural line. So this is the study from the COVID-19 confirmed COVID patient. Now the physician also performed a quick focused focused echo also over here, and you can see the changes in the heart also. Here is another video clip. You can see over here the lung. It is the lung scanning, and you can see this. You see the patchy appearance. The normal lung was there in the beginning, and now you can see all the distribution of the B lines. Now over here the heart looks normal, so is the early pneumonia with the normal heart function. Okay. This is a small COVID-19 assessment. Just a small diagram. You can see if the lung is normal, so there is no need to review. If you find any minor findings on the ultrasound, even if it's outpatient or inpatient, so lung ultra follow-up exam is considered. In the intermediate finding, the inpatient, the serial lung ultrasounds are recommended. And if you find advanced ultrasound findings, so then you have to take decisions to ventilate or to decisions to turn the prone. But everybody follow their own hospital policies. And so with this we are done with the today's talk, and thank you so much for your time, and be safe.